If patients don't trust you with their secrets, they won't trust you with their lives. Autonomy, one of the core pillars of medical ethics, collapses the moment trust disappears. Today, we are breaking down the three standards that protect autonomy every single day in clinical practice: privacy, confidentiality, and full information disclosure. We will explore the rare but critical exceptions, those specific moments when ethical rules must bend to protect the patient or the public. Understanding these exceptions is essential for step 3 and for the real world practice. So, our three pillars protecting the patient autonomy are privacy, which basically means this is a patient's right to control access to their body, space, and personal information. Number 2, confidentiality. This is our duty as clinicians and healthcare providers to protect patient information and not disclose without authorization. The third part, that it's a pillar or standard to protect and uphold autonomy, is full information disclosure. The duty to provide complete information so patients can make informed decisions. Autonomy is not something you simply give a patient. It's something you protect through these interconnected systems. Each standard has a clear purpose, and each has a specific ethically justified exceptions. Knowing when to follow the rule and when the rule must bend is what step 3 will test. In life, we have all these rules and laws and standards, but sometimes they need to bend to face exceptions, to face some other challenging situations, to protect and prevent harm. They are called exceptions because they are not the rule, but they are the exception to the rule. Now, just to speak a little bit more about privacy. Privacy is the patient's right to control access to their body, space, and personal information. Privacy means the patient decides who is in the room, who hears sensitive information, and who touches or examines them. Yeah, every time they can decide that. This is the patient's shield, their fundamental right to personal boundaries in healthcare settings. Let me give you an example. You are about to ask the patient about sexual history. Their spouse is sitting at the bedside. Privacy means you politely ask the spouse to step out because the patient has the right to decide who hears the conversation. You see, spouse. And still, you need to ask her to step out um, to allow for this information to be shared. He said there are usually exceptions when privacy must be breached. Privacy is the patient's right, but there are moments when privacy must be overridden. For example, in medical emergencies where immediate access is required, unconscious patients where privacy cannot be meaningfully exercised, safety checks during abuse evaluations, and so on. These aren't violations, they are protections that serve the patient's best interest when autonomy cannot be exercised. Our sacred promise. If privacy is the patient's shield, confidentiality is our promise. The core principles. Confidentiality is the clinician's duty to protect patient information and not disclose it without authorization. You learn something about the patient through labs, exams, conversations. That information is protected. This is a strong rule central to the therapeutic relationship. Okay? Let me give you a scenario. The patient has HIV and says, "Do not tell my spouse." Confidentiality means you don't disclose it, even if the spouse asks you directly. But again, it's not absolute. Confidentiality is not absolute, just like privacy before. There are specific, well-defined circumstances when breaking confidentiality becomes the ethical and legal obligation. These exceptions exist to prevent serious harm to the patient or others. Understanding these exceptions is crucial for both clinical practice and step 3 success. The key is recognizing when the duty to protect information must yield to the duty to prevent harm. This is key. So when can we break confidentiality? Number 1, mandatory reporting. And this is a legal requirement to report certain conditions to protect vulnerable populations and public health. For example, child abuse or neglect. Suspicion alone is adequate to trigger reporting. You don't have to be sure. Elderly abuse or vulnerable adult abuse. Threats to public health like TB, measles, certain STIs. STI is usually different from state to state. Gunshot wounds and certain injuries, they need to be reported. It depends again, it differs from one state to another. Number two, exception to confidentiality, or when you can break confidentiality, is duty to warn. And this is called Tarasoff principle. Tarasoff is a very famous case in the past. And without going into details of this, the Tarasoff principle, or the duty to warn, when a patient poses a credible threat to an identifiable person. So comes to you, to your office or in the hospital, and says, I'm going to harm Mr. or Mrs. X on the day so and so. Very specific information, very identifiable victim, potential victim. Then you need to break confidentiality in that case. It must be a specific identifiable person. The threat must be credible and serious. The harm must be imminent. In that case, warn the potential victim and notify law enforcement, both. The third exception is legal obligations, court-ordered disclosures and specific legal requirements. For example, if the person has, or the law, the officers or the law enforcement has valid court orders or subpoenas, DMV reporting for conditions affecting driving safety, like uncontrolled seizures, for example. They shouldn't be driving, so you need to notify somebody if they are not doing it voluntary. Again, reporting to DMV situations varies from state to state. Some workers' compensation claims, confidentiality can be broken in such cases. These exceptions are not loopholes. They exist to prevent serious harm and are narrowly defined by law and ethical guidelines. The third standard, this is comprehensive disclosure. And what we mean by that is the duty to tell patients what they need to know to make informed decisions. This is a patient's right, again. And it's our duty to comply with that. This is the foundation of informed consent, and it's equivalent informed refusal, because the decision can be an accepting something or consenting to something or refusing. Okay? You must explain risks, benefits, alternatives, and consequences of refusing treatment. All this needs to be included. Complete information empowers patients to exercise true autonomy. So what are the key components to full disclosure? The nature of the proposed treatment and procedure, risks and benefits of the intervention, reasonable alternatives and their risks and benefits, and the consequences of declining treatment. All this needs to be included in disclosure of the information about a certain intervention. Okay, what are the exceptions? Again, just like the other standards, you can have exceptions. True emergency, when delay to obtain informed consent would threaten the life or result in serious harm. Examples, performing emergency intubation on a patient with respiratory failure. You can't just really wait to give them full information before doing that. Number two, implied consent. Actions a reasonable person would consent to in an emergency. For example, performing CPR on a collapsed unresponsive patient in cardiac arrest. They are in cardiac arrest. You can't wake them up to get consent. So do what you have to do. This is another exception. Therapeutic privilege, this is really not a very well-defined situation, but sometimes they say you can withhold information from a patient when you think telling them or giving them the full information will cause a lot of psychological harm that can actually be cause more serious consequences to their health and be in the way of them benefiting from whatever you're going to do to them. So sometimes you need to always hold information, but this is rare and it shouldn't be. Like if they are going to cry or having some distress, this is not what we mean by this. Okay, and patient waives the disclosure. When a patient is with capacity, explicitly states that they don't want detailed information. I don't want to know details, just treat me. A lot of patients say this, by the way. So this is kind of waiving the right to having full information. But you need to document all this. You need to document that you tried to tell them and they didn't want to hear it. They just wanted you to proceed. Let's look at the scenario. The patient refuses a life-saving procedure. You must explain the risks clearly and ensure they understood. If they have capacity, you must honor their decision, even if the consequences are serious. And by serious, I mean even death. People can choose that. They have the right. Okay, let's look at how these work together. Confidentiality, our duty to protect the information they shared with us. The privacy is the patient's right to restrict access to their body and personal space. Disclosure, it's our duty to inform and to give full, complete information to the patient so that they can make informed decision. And this informed decision could be a consent or a refusal. Informed consent or informed refusal. When you put these together, they create the ethical structure that supports autonomy. But the moment one breaks, privacy ignored, confidentiality violated, disclosure is incomplete, autonomy crumbles, and trust goes with it. Let's go over some scenarios that happen a lot in real life and appear a lot in the exam. Privacy at the bedside. A patient's brother is in the room during rounds. You need to ask about drug use. What should you do? Here, ask the brother to step out. Privacy belongs to the patient. They control who hears sensitive information. And this is a very common scenario, by the way. Very common. You really need to be able to deal with these situations. Duty to warn. Patient is homicidal and says he plans to shoot an identifiable person. Do you break confidentiality? The answer is yes. Duty to warn. Specific, credible threat to an identifiable person requires breaking confidentiality to protect the life. And here we contact law enforcement, the intended victim. Both. Another scenario, assessing capacity. A patient refuses high-risk surgery but cannot repeat back the consequences. To be well-informed, you need to understand, repeat back in your own words what you understood out of the conversation, and you need to show the reasoning, and you need to provide your consent after that. So he refused, the patient refused, but they couldn't tell you back what are the consequences of their refusal. In that case, you need to really assess their capacity before accepting their refusal. Okay? Understanding is required for informed refusal. Fourth scenario, mandatory reporting. A child has bruises in various stages of healing. Do you report? Yes. Report immediately. And in cases of suspected child abuse, if you suspect, that's enough. Suspicion alone triggers mandatory reporting. You don't need to prove that or to really be sure. Let's take a case. 45-year-old woman with newly diagnosed HIV infection is hospitalized for pneumocystis pneumonia. She is alert and has decision-making capacity. During rounds, her husband approaches you in the hallway and says, I know something serious is going on. She is not telling me everything. You are her doctor. What's really going on? The patient previously told you she does not want her husband to know about the HIV diagnosis at this time. What is the most appropriate response? A, tell him the diagnosis because spouses have the right to know. B, ask him to sign a release form, then disclose. C, encourage him to ask his wife directly and offer to facilitate a joint discussion. D, refuse to discuss any aspect of her care. And E, inform him only that she has an immune problem. The correct answer is C, which is encourage him to ask his wife directly and offer to facilitate a joint discussion. What we are testing here is confidentiality and respect of autonomy, of course. You cannot disclose HIV status without the patient's permission. However, respond compassionately. Invite the husband to talk with the patient and offer to support that discussion. So why not the other action, the other responses? A, B, and E all constitute breach of confidentiality without the patient consent. And E, by the way, you are hinting to some immune problem. HIV is a non-immune problem. So even if you are hinting, it's still disclosure. D, people might ask, why not D? He said he refused to discuss any aspect of her care. That you protected confidentiality here, but it's necessary or unnecessarily cold, okay, and unhelpful. Better to support communication between spouses. Here, remember, we are in the humanitarian field, okay? And we need to have some rapport with our patients, their families, and so on. You can't be that rude and abrupt with the patients and their families. So be delicate about what you say. Yes, you are not going to divulge any information without the patient's consent, but you don't have to be abrupt and rude. You can do it sensibly. Okay? Usually offer to be helpful. I'll be there. Talk to your wife, and during this discussion, I can be there to help by any way needed. Now, another case, 62-year-old man admitted with decompensated heart failure. During the morning rounds, his wife is at the bedside. You need to review his alcohol use and sexual history. The patient appears uncomfortable and looks at his wife. The most appropriate next step is ask the wife politely to step out so you can speak to the patient privately. Here, the key principle about this is privacy means control over who is present during examination discussion. Patients have the right to private conversation, especially around sensitive topics. Presence of family doesn't automatically mean consent to discuss everything. Very common scenario, and it happens on a daily basis when you are a hospitalist or work in a hospital setting. Another case, 16-year-old girl comes to the clinic requesting contraception. She is sexually active with one partner and doesn't want her parents to know. She appears mature and understands risks and benefits. Your state allows minors to consent to contraception without parental involvement. The most appropriate response? Prescribe contraception and assure her that the visit will remain confidential. Okay. The key principle is minor consent for sensitive services like sexual health, STI treatment, contraception, mental health is permitted in many jurisdictions. Confidentiality must be protected to encourage access to care and prevent harm from delayed treatment. I have to mention a little bit of information here. When you are dealing with such patients, when they are minors and they are they are sexually active, one of the things that people need to be looking at is that she's not being taken advantage of. For example, her partner is equal to her in age. He's not, he or she is not an older person. And in that case, it's against the law. Okay? There is no much discrepancy in power, and there is no taking advantage of her in any situation. So this sexual activity, if it's within the confines of, it's lawful and it's safe, and she is willingly doing it and consenting to it, then you can proceed with your confidentiality rule and prescribe to a minor in these situations, because generally minors need to involve their parents in the decision making usually, but these are the exceptions to this rule. Okay, duty to warn. 28-year-old man with schizophrenia tells his psychiatrist, my ex-girlfriend ruined my life. I bought a gun and I'm going to wait outside her workplace and shoot her next week. He refuses voluntary hospitalization and leaves the clinic. Just left. What should you do? Do nothing. Statement is protected by confidentiality. That's option 1. Option 2, call the ex-girlfriend and warn her directly. Option 3, notify law enforcement and take steps to protect the potential victim. Option 4, schedule an earlier follow-up appointment. Option 5, call his family to monitor him. The correct answer is option 3, which is notify law enforcement, take steps to protect the potential victim. Call her, call somebody new, close to her. These two needs to happen. This is a Tarasoff principle. Okay, law enforcement and the victim. So this is the duty to protect. When a patient makes credible, specific threat toward an identifiable person, confidentiality can and must be breached to protect life. This case meets all 3 criteria: credible threat, which is purchase the gun, specific plan, identifiable victim, ex-girlfriend, known workplace, and imminent harm. He gave you the time frame. He will do it next week. Why the other options are not right? First of all, number 1, incorrect, because confidentiality is not absolute when there is serious imminent harm to an identifiable third party. Option 2, calling the ex-girlfriend may be part of the response, but involving law enforcement is crucial for adequate protection. And options 4 and 5, grossly inadequate to protect the threatened person from imminent specific danger. They are not, you can't wait for his next appointment. That's really not adequate. So master the rules or the standards and master the exceptions. That's what you are going to be asked about in the exam. Privacy, confidentiality, and the disclosure, full disclosure of information. And the disclosure has certain elements that need to be disclosed. Each standard has exceptions: narrow, clearly defined, and ethically justifiable. The exceptions exist to prevent serious harm, not as loopholes. When you master these concepts, step 3 becomes predictable, and clinical practice becomes safer, more ethical, and more human. You will recognize the pattern, follow the rules unless a specific exception applies. Know the exceptions, apply them judiciously, and always document your reasoning. Trust is built one protected conversation at a time. Guard it fiercely, break it only when you must, and always in service of preventing serious harm. Thank you very much. Next video will be about mandatory reporting, which is another ethical issue that needs to be addressed, and any connected topics to it will be I will follow this way of explaining through clinical scenarios and questions, which I think is more interesting and informative. Thank you.